Hi everyone, welcome to our first Tech Talk in 2023. Before we start, let me go over some housekeeping issues. You will receive an email for the codes to seek out CME credit. If you don't receive the email, please send Deborah Reese a note. Her email is deborah.reese@christianacare.org. You will also find her email in the chat box. Today is our first Tech Talk in 2023. Please also mark your calendars for ID series next week. On January 12th, Dr. Mary Mitzdarfer from University of Delaware. Her talk title is Radical Welcome in Healthcare Setting, Increasing Healthcare Utilization and Health Equity. On February 2nd, we will have a Tech Talk and host Dr. Jessica Webster from Drexel University. Her talk is ArcGIS Location and Allocation Analysis as a tool for evaluating disparities in mammography screening facilities. So today in our first Tech Talk in 2023, we are delighted to have Dr. Louis Luangkesorn, lead data scientist from Highmark Health People Analytics team. Before joining Highmark, Dr. Luangkesorn was an assistant professor of industrial engineering at the University of Pittsburgh. Dr. Luangkesorn has received his PhD in Industrial Engineering and Management Sciences from Northwestern University. He has many years of experience working in research and healthcare. He has applied his expertise and skill set in many projects and collaborated with multiple health systems, including Veteran Administration Pittsburgh Healthcare System and Children's Hospital of Pittsburgh. Today, Dr. Luangkesorn will share his research about predicting the peaks and duration of waves during the COVID-19 pandemic, and this research was also applied to 3 metropolitan areas in Pennsylvania. So Louis, please start your presentation. Thank you.
Okay. Yes, hello, my name is Louis Luangkesorn, and as Mina said, I'm lead data scientist at Highmark Health. Most of my work is in people analytics. However, this work that I'm presenting was begun when I was still at the University of Pittsburgh. And when I was there, I did a lot of work with Graduate School of Public Health and their infectious disease modeling teams. Just a reminder that the usual disclaimer that these slides are not the official position of Highmark Health or any of its affiliates. So I'm going to cover purpose, the motivation behind this work for Highmark Health. I'll give you an introduction to infectious disease SIR compartmental models. I'll discuss the data sets, which is probably the most interesting part of this talk. And then we'll look at how our computation results fitting the model to the data for these 3 metropolitan areas and extensions of the base model with vaccines and our current state. So Highmark Health is a blended healthcare company. So we're probably best known to you as the health insurance, covering from Western, Central, Northeast Pennsylvania, Western, Northeast New York, Delaware, West Virginia. Our strategy comes from belief that the current health system is fundamentally broken. And for both people who use it and the clinicians to help them. And so our view, we call this our strategy is living health is reinventing healthcare. The issue that we face with working with COVID, especially the hospital network, which is in Western Pennsylvania, is that we get information from the state health agencies providing guidance from the COVID-19 models that exist in various locations, including the University of Pittsburgh, where I was. But the guidance we've been getting from the state is at the state level. And we work, of course, across the state. And then even in Pennsylvania, Western Pennsylvania, Central Pennsylvania, and Eastern Pennsylvania all experience COVID differently. And so what we needed at Highmark was models that looked at on a more regional basis and to provide guidance, especially our healthcare providers partners, probably early estimates of the peaks, magnitude, the timing, durations of COVID-19 waves, so that both on the healthcare provider as well as the insurance sides, we can institute policies and procedures to respond to that, to help manage our resources. So infectious disease models are generally based on dividing the population into compartments. So the base model, which is what you learn in school, for example, is the SIR model, susceptible, infected, removed. So susceptible are people who could potentially catch the disease. Infected are those who are infected and are can spread it to others. And they're removed, either recovered or through mortality, which means that they are not in the base model, they cannot get reinfected. And the reason that we create these models is we can model interventions that show how interventions can impact the flow from people from one compartment to another. Usually we're more interested in susceptible and infected. One thing that we're trying to do here is something very different. We're not trying to model interventions, which is what I did when I was in academia. But we want to know, and given the fact that the world that we work in is as it is, what is the current infection wave going to look like? Now, the assumptions of the SIR model are three, and they're on their face, they obviously aren't true here. So we'll talk about how we get an approximation of these assumptions. First is the system is a closed system. So no births, no deaths, and people are not moving out. Second is that once they are moved to recovered, they're removed from the system so they don't get reinfected. Third is that they're a complete mixing within the population. And there are two parameters that we have to worry about. Beta represents the rate of transmission, and this can be further broken down to the infectiousness of the agent and social mixing. Okay, and then there's a parameter nu, which represents the rate of recovery. And so the goal for this work is to find beta and nu for the current wave. Normally, like for example, for flu, they will do lab estimates to find beta, and then social mixing is characteristics of the population. So you have historical data. In our case, we don't have that. So to implement these models, we're going to use as a unit of analysis metropolitan areas. So our claim is that this approximates the closed system because metropolitan areas are defined by the fact they have high internal traffic versus outside external traffic. So that's an approximation of our closed system. And for the Highmark Health data, we have three metropolitan areas that are promising for this purpose. We have the Pittsburgh Combined Statistical Area, at least the Pennsylvania portion of it. Harrisburg Combined Statistical Area, which is in central Pennsylvania. And the Allentown Core-based statistical area, and here we know it as Lehigh Valley, which is to the northwest of Philadelphia. Our population are insurance clients, and so in these three markets, Highmark is probably the largest insurance company there. And our assumptions here for this to be a representative sample is one is that we have a reasonably large and broad-based market share. And when we say large and broad-based, we're looking at the fact that Highmark participates in many different insurance markets. So we have commercial, in other words, our business customers, Affordable Care Act, which are our individual, and then Medicare and Medicaid. And then we further examine this to see if we have a good cross-section in society. And by good cross-section, we brought in our experts in social determinants of health and asked them this question. So looking at their lenses, looking at the subpopulations they know about, do we have a reasonable coverage in each of these so that we have a good sample of the overall population? Next thing we have is propensity for entering our population. So for to get infected, we are looking at individuals, customers that submit claims that are COVID related. And one thing that we're going to say is while there are many questions about case data in general, claims data where it does require that a person feels sufficiently poor that they wanted to access the healthcare system. So it's actually a fairly high bar compared to just trying to count cases in the general population, but we think it's going to be relatively consistent. And the last thing we need to do is, given the fact that the complete mixing assumption is not going to be true over an entire metropolitan area, we're going to put a factor in that adjusts the population. And effectively, this factor is accounting for social distancing or lack thereof. Okay. The last thing we're going to talk about is what are we trying to model? The model is not intended for a steady state analysis. So we're going to use it only to look at COVID-19 waves, which are usually associated with the introduction of a new variant into a region. And so we will begin the model when case rates start increasing from some baseline steady state. Next for data I should stop here 1 second. Do we have any questions here? I guess when we're doing this work, the big discussion that we had internal at Highmark was the concept of looking at social determinants of health as a good cross-section of society. Okay, moving on. The next thing that we want to look at are vaccination status. The vaccination status is either based on insurance claims, so someone gets a vaccine and they submit a claim that Highmark has to reimburse them, or state-provided data, especially in the case where states provided vaccination clinics. So for the state-provided data, we then applied some fuzzy matching to match records with our insurance clients. Our county public health department had commented that this was very difficult for them. And I think we had an advantage being the insurance company that our insured customers had incentive to make sure that the insured data was correct. So we were matching on something that was known truth. Next, and then the vaccination status, given that we have it, we now have, are they fully vaccinated? And also we have the date of the last booster. In the computation results I'm giving now, that wasn't so important, but going forward, the data last booster is going to become more and more important. Then we have our cases, our positive results. So again, we count them as a case if the claim is flagged that COVID-19 was present. And then we have, in these cases, we have an estimated date of infection. And again, the provider is allowed to backdate this. So it can be before the date of service of claim if the provider thinks they have a better date. And again, we have the claim matched to the client. So we are able to match them to client, and also that means we also know their vaccination status as of the time of infection. So we're going to implement compartmental models, again, for susceptible. I'll start with winter 2020, which goes from December 2020 into the early months of 2021. So this is pre-vaccine. Our correction factor on the population is going to be based on the fact that we are looking at those who are socially engaged. A large portion of the population at this point is still active in social distancing. And again, when infected, I'm going to go into this in a little bit more detail in a moment, but we take their infected data, estimated date of infection, and then we create a distribution around this date of infection for how long, for what percentage of the people are infectious for a given period of time. Okay. So pre-research in COVID-19 says that people are often contagious from 2 days before they show symptoms. And then we had a research paper that provided a probability distribution for how many people are are still infectious by day, and it runs up to 14 days. So I think it was 75% are still infectious 3 days after symptoms. So in other words, a total of 5 days. 50% were infectious 10 days, 7 days after, and so on and so forth. And then only maybe 1% of people are still infectious at day 14. So we use this to create an implied infectious population from our case population. And this is what we used in the SIR models for I. Okay. So when we try to fit these, so we took again, this is winter 2020, starting in October 2020, going through February 2021. And we approached the SIR model as a system of ordinary differential equations. And we solved the initial value problem using a standard library in R. And we applied it to the 3 metropolitan areas. So the red dots are implied infected, which was created the way I just described. And then the black line is the model after we fit the parameters. And so what you see here is this COVID-19 does follow the model. Given the fact that we're using metropolitan areas, which are not closed systems, so that was a concern. We see that there is a dip in the middle, which happens to be right around Christmas and New Year's, and so we think that that is more of a symptom of the decreased reporting activity during the holidays, not a true indication of case spread. And we see that again, the cases follow the curve. I mean, the infected population follows the curve in the post-holiday period as well as the pre-holiday period. So the model we kind of believe is a good one, and the assumptions are reasonably good. After starting in 2021 is when we started vaccinations, and so we extended the model to now look at vaccinations. And so we have a 2-population model, and again in 2021 we started having Omicron, which had reported vaccine evasive or immune evasive characteristics from those who have gotten the vaccine based on the early versions of COVID, as well as people who have been previously infected. And so we have now a 2-population model because vaccinated individuals can be infected again. We'll have separate potential correction factors for a mixing assumption. At the time, with some early reports on the efficacy of the vaccine for Omicron was 75% effectiveness. We included that as a correction factor in the vaccinated population. And the way that these 2 populations mixes are the I1 plus I2, which means any infected person, vaccinated or not, can transmit to any person infected or not. For dividing the population into unvaccinated and vaccinated, we used only the vaccinations as of the beginning of the wave. So our reasoning for doing this is that when we looked at the vaccination data, we saw no changes in vaccination rates that are correlated. In other words, the vaccination rates where vaccines were happening at a constant rate regardless of infections or other cases or other news. So we fixed these populations as of the beginning of the wave. And then we allowed this to generate a different infection and recovery rates. So there's a B1 and a B2 for the unvaccinated and vaccinated populations, and NEU1 and NEU2 for the vaccinated and unvaccinated populations. The model, since we have to start at a local minimum, we had to start fitting the model essentially after the Christmas holiday, which is a problem for us. And so this is what we have looking at the Omicron 1 wave. And then the top line, the top row are is the vaccinated population. Bottom row is the unvaccinated population. At this time, I think majority of the population is vaccinated, and so this is one of the reasons why, at least for Pittsburgh, the vaccination model is in fact higher, but that's just because the number of vaccinated population is higher. And again, for both unvaccinated and vaccinated, the model looks pretty good as a whole. What we're then interested in is how long does it take to fit the parameters beta 1, beta 2, mu 1, mu 2, because being able to come up with these parameters early on allows us to make predictions on the rest of the wave. And so what we see is, again, we're solving the initial value problem each day with the available data. And the initial days are, again, with very little data. There's every data point causes lots of changes, and eventually it stables out, it smooths and converges somewhere. And so we essentially converge in late January 2022. To look at what this looks like, again, 5 days after, so this is December 30th. 5 days after, we don't have a good model at all. 10 days in, we have a curve, but it's still in flux. So in other words, every data point does change it. By the time we get to 15 days in, this curve, the black line, doesn't change for the rest of the model runs. So by 15, in this case, day 15, we had a good model, and we have good estimates on the magnitude and peak of the magnitude and timing of the peak. Now in this case, the time this point unfortunately coincided with the peak, and that's probably because of the fact that we couldn't really start this until December 25th. We basically didn't have enough data. So when we did the same exercise with the winter, October 2020 through February 2021, again we were able to still get a good model within about 15-20 days, but that was well before the peak actually occurred. So that one actually gave advance notice. This one we didn't, but again, that was because of the winter holidays. The tail end here, the reason cases start going up is that our regions are no longer in a wave per se, but they're approaching our standard steady state of infections. And so the models are intended really for looking at waves, not steady state, for example, like we have right now. The state of the model now is we're starting to look at partial immune evasion. So we had this ready for Omicron BA.5, and what we're wanted to start looking at is what happens again with this idea that your vaccinations are only partially effective, and also that we want to start putting in previous infections. So with Omicron 1, the reports we were getting is that previous infections, the reports we were getting was that previous infections did not provide immunity for Omicron. For Omicron BA.5, the report was that if you had Omicron before, you had partial immunity. So we're starting to add that in. And other things we're looking at, let's see, The next thing that we need to do for use in for the providers is to correlate the cases that we see in the infected population to hospitalizations. And so here, the green is our implied infected cases, which of course our model does predict. And the red is the hospitalized, again, within the same population. And so one of the things we see is that there's a peak, and depending on which region you are in, the peak in hospitalizations is associated with the peak in the infected population. And our desire is that the hospital networks will then take the past data, past patterns, and then match their peak in load and demand to our insured population cases, and then they can start making estimates on their operational planning over the next few weeks of how they work with their resource management. So the goal here again is if we have a model that can provide some advanced notice on the magnitude and timing of a peak of a wave, we can pass this on to both our more frontline insurance on the insurance, as well as our provider partners, and then on a metropolitan area provide guidance both for providers and administrators. I think that administrators, again, we have Allegheny Health Network, which is in Western Pennsylvania, and the Omicron one. Their question was, do they need to be doing things for staffing, supplies, and such? And we want to be able to give them that information that they can use to set those kinds of policies. The models in place for us, again, in Highmark Health and by extension through Allegheny Health Network. And so this is going to be used along with other information sources that we get from the state health agencies, our own census, in the event of a major COVID surge. So things that we're going to try to add in is looking at the possibility of looking at prior infections and partial immunity. So the models I gave you before, those were in settings where prior infection did not provide immunity because of the new variant. And this is not necessarily true for BA.5 or the new variants that seem to be emerging. We'll find out. And then this idea of partial effectiveness as vaccines start to expire. As I start including these other details, I'm going to start having to balance fidelity with the cost and complexity. The more of these compartments, the breaks in population that I include, the harder it is to fit parameters. And so there's going to be a point where I will have to say that we don't have enough data for breaking the compartments into small and smaller parts. And it may not provide enough improvement on the prediction. Given that our goal here is understanding peak magnitude and timing, breaking the population to the smaller pieces may not help. Another question we are starting to have more of is that what's the effect of the out-of-home testing? Does it appreciably change our case counts? So in the case reports that we get from the state public health, it's a big change because people are going to home testing versus going to, say, a pharmacy or some other provider. We think that our model data is going to be more consistent because our model data really is people who are infected and symptomatic to the point of accessing the healthcare system, which we think is a more solid bar than the case reports, such as the kinds that we get in public. Some acknowledgements. Again, I started this in the spring of 2020 with some students at the University of Pittsburgh. We've had conversations with Dr. Brogan at the Allegheny County Health Department, especially about the difficulties in matching vaccination records to people. At Highmark, Steve Ways is one of the coordinators for the data sets associated with COVID-19. Richard Clark is our chief analytics officer, and so he was the one who was approached by the hospital network. And then I had many comments from the Highmark Health Journal Club, that meets regularly here at Highmark. And with that, I'll take more questions.
Thank you so much, Lee. So now we start question section. Do we have any questions from the audience?
I have a question.
Go
Thank
ahead.
you so much for great presentation. So I mean, I think in your last slide you recognize that your case is really based on the claims, so people who are sick enough to see a doctor, but it really underestimates. I mean, the case basically underestimates the number of COVID infections, which can also lead to another wave or another or higher wave than predicted. I'm not quite sure if, I mean, and I know you recognize it, that it's not your case, but is it something you can comment about, and how would it differ, or could you do some imputation or add a correction factor for this?
Yeah, I think I can address the intent of the question. So again, the question is, yes, we know there are cases. We know that our insurance data, because it's based on claims, is going to definitely be underreport claims. It's not going to be a good measure of cases and the true infected population. But our intent, so models have purpose, and models are only good for their intended purpose. And our intended purpose was trying to forecast essentially the burden on our healthcare providers, which are in fact people that are going to be seen because of this. So, our intent is that the infected is correlated with the provider burden. And again, so not all people with cases will access the healthcare system, in which case they're not a burden on the provider. Yes, they might be a burden on the rest of the public health system. And there are other issues that are involved with that. But for our particular case, looking at the burden on the provider system, and also on the insurance side, there are actually interventions we do on that side too. And we're trying to allocate resources for that as well. But given that our intent is looking at a burden on the healthcare system, it was probably a more useful thing for us than trying to actually be a true measure of cases in the general population. Okay, so I see a question on the chat. So the question was, what is the reaction from the health department and the healthcare system based on work we conducted? So we haven't really talked about with the healthcare department. Again, we're only one hospital system out of many that they work with, and we're only, I think, one insurance company of many in their area. We've kind of like talked a little bit about our thoughts that we might have a better way. Our ability to match vaccination records to people might be better, because we had been talking about their difficulty that they have. So we think we do better than that. On the model itself, so we haven't applied it. It was ready for use when Omicron BA.5 came. But for so if we had a situation like we had for Omicron in January, where we had a very large spike, and they came to our analytics to ask us for advice, we would have been ready for it. It just we got lucky, and it wasn't as much of an issue. So I think it's now in place, and I think in other areas of analytics trying to inform practice, I think everybody understands you really don't know how it's going to be used until it actually gets used. So it's in place. I've been checking at it for the newest. I've been checking at it, given the fact that the new variants are coming in from Europe and Asia. So hopefully it won't be an issue, but if it is, we'll be adding it to the information that we provide our AHN healthcare partners in their planning. So it's part of our reporting dashboard on COVID-19 now.
And I think the question continues.
Yeah. Can I use it for additional infectious disease models? So the SIR models, I know that University of Pittsburgh has a much more finer fidelity model, agent-based model that they've been historically done every flu season. And so I think in principle you could do the same thing for any infectious disease where effectively it's a new disease. So things that are constant, steady state throughout the year probably doesn't help very much. But yes, for the spikes, I can see it being used. I know SIR models are used for flu. I know many of the academic groups use various types of this for flu. So I think that use case is possible.
I have other questions.
Yeah.
You mentioned that you had, and I was not sure I understood, related to the social determinants of health. Did you control for social determinants of health, or how did you include this information into your models?
So my claim is that so infectious disease, again, this is from my background of working with modelers at University of Pittsburgh. We know that if you do not check to ensure that your data doesn't include all cross sections of society, and the key threat here tends to be that you're missing a whole section of society, so it becomes invisible to your model. And this is one of the things that and what makes a subpopulation invisible is often related to things that they look at in social determinants of health. So we asked our people, our staff that work in social determinants of health, how confident they were in these metropolitan areas that we did have a good cross section, that we don't have really big holes that usually threaten the effectiveness of these infectious disease models. So for Pennsylvania, we have a long history. So for example, for us at Highmark, I wasn't really confident in doing this with Buffalo, New York, because our social determinants of health staff don't have as good understanding of that area but if they did, I would do this I would add Buffalo, New York to this type of model. But yeah, but one of the threats to looking at infectious diseases across large areas is that, right, you have an invisible pocket. And that's why we looked at social determinants of health. And so it was more of a qualitative evaluation. Is our data, does it have good penetration into pockets that are often not represented in health data?
Great, thank you. Any other questions? Colleen, you can go on if you have more questions. I always learn from your questions.
Good for now.
I remember I had this chat with you in the conference about the vaccination data. I was wondering, like, where it's at. Like, do you have any updates? I know you were working on that.
Right. I think our big thing with the vaccination data is having the vaccine start to expire. So in the beginning, our question was, did you have a full course of vaccines or not? Now our question really is going to turn into when was the last time you were vaccinated? And especially with the newest variants, it might even become an issue of, has it been since, so our big question now is, did you get the latest boost, the vaccine, or the previous one, and does it make a difference? In other words, is it going to be worth having two subpopulations for vaccinated, current and not current, or because we know that the effects are different, or do we just have people who are past 6 months, do they lead the vaccinated population? And so that's kind of like my next big question that I'm on. What do I do with people with vaccines where the last shot was more than 6 months ago?
Yeah, that makes sense. And
Yeah.
you're surveying people about their vaccination.
Okay, so we get it in two ways. So one is if it's vaccinated, if you go to a pharmacy, for example, they'll ask for insurance information. So they'll send it to us directly from whoever provided it. Also, the state provides us, and I'm actually not quite sure how this works. If they run a clinic, if there's a state-run or a government-run clinic, they provide the information for people they think that, because they have a list of our clients, they provide that information to us. That information is very error-prone because you have people that are writing things out on paper, so our county health department has lots of trouble with it. But we try to match it too. So we have two ways of getting vaccine information. But it's either a claim was made, either the person, or if it's a clinic, we get it from the state. So right, it's not a survey. We get it more automated process than that.
Yeah, that makes sense. It's much easier if it comes directly to you, obviously.
Yes, right. We don't have the matching problem that the county health department does.
And does your study population also include, or your population include also children?
Yes, they would include children because they would be dependents of our insured. Yes. And either through our corporate or individual or through Medicare, Medicaid. Again, so that we have this broad cross section. Yeah, the insured would be included because the insured are as families. We didn't try to break that out ages. Again, the issue is it's hard enough to fit the model with only two compartments, with only two subpopulations. As I think we have to, given the fact that we're trying to fit mathematical models, it's going to be a compromise between having a better fidelity model, but that becomes harder to fit.
And are you still working on these models like COVID or flu, or is there a shift in terms of priorities in Highmark?
I think we're only doing this for COVID. So for Highmark, COVID-19, I think for us is still a weird thing. We don't treat anything. There's nothing else we treat like it. So we haven't thought about using it in other places, right? Like for example, flu or RSV that just came through. We haven't had interest in that yet.
Yeah, this season has been really interesting, especially with like spikes in RSV in kids. Did you work on any models related to that, or?
Right. No. Again, this was a case where it hasn't been my area. I think what would happen is if we had another wave and we had experience using the model, maybe that would be the point where you start thinking, where else can we use this type of model?
Right. That makes sense.
Yes. So this is one of those. We're probably glad that Omicron 5 wasn't so bad here, but it would have made an opportunity to use the model, and we'll see what happens with the newest variants that come here.
Great. Any other questions from the audience? No? Well, thank you so much, everyone. Thank you, Lee, for being with us today. And a reminder about the credits, you can reach out to Deborah if you don't receive the email. And the presentation is going to be available in a couple of days on CTR website. And if you want to get access to that earlier, you can always reach out to Deborah Reese. So if there are no other questions, I think we can end the session. No? Okay, thank you so much.